I think now the evidence in favor of radial is getting much more compelling than before. And so now the community has, from one side, a clear-cut answer to the question which was lingering in a way. But I think now the community should start looking forward and maybe not doing the mistakes that we have done in the past. I think new interventional cardiologists nowadays need to be trained in both access sites, not just one, and then depending on the preference you use either of the two. I think now interventional cardiology needs to be trained with respect to transradial intervention. And this is, I think, a very important topic for the United States, because actually radial approach here in the United States is quite low. It's much, much higher in Europe, which is, I would say, already 50–60% of the procedure. Here in the United States is probably in the range of 10–15%, so there is huge room for improvement here. The problem of radial access that you need to do a lot of procedure to become proficient in radial access. And indeed, when we stratified the outcome based on the center's expertise for transradial intervention, we have seen a huge signal showing that the center has to have specific radial expertise, otherwise it's not going to work. And actually, at the forest plot, a subgroup analysis, both for MACE, NACE, and mortality, we have seen a clear signal so that if the center is doing more than 80% of procedure transradially, there is a mortality benefit. If the proportion of TRI is lower, the mortality benefit is not there. And to be honest, I did it on myself many years ago because I grew up as a femoralist. I was taught the technique transfemorally, and then I got this interest transradially, and actually I went to work to France on purpose to pick up the technique. And I can tell you that takes probably 3 to 5 years to get there, and depending on the number of procedures you are doing. So you have to start gradually from diagnostic cases, and then simple PCI cases, then complicated elective PCI cases, and then I think ACS is really the last bastion, because ACS, especially STEMI, 4 o'clock overnight, you are alone, you need to know how to handle that. So it takes a lot of time for sure. But at the end of the day, the only difference between radial and femoral is the pathway to get your catheter in the coronary ostia. Once the guiding catheter, that's what we call the guiding catheter, so the catheter through which we deliver things basically in the coronary arteries, is positioned well in the coronary ostia, there is not that much of a difference between radial and femoral. I think now we need to improve the technique, and we need to tackle the issues that radial intervention specifically has. The first one I would think of is the fact that in a sizable proportion of patients, once you have delivered your intervention transradially, if you don't close the artery properly, you completely occlude the artery, which means that the artery is not accessible anymore for a second possible intervention. This occlusion is 99.90% of cases completely asymptomatic. The patient does not even realize, because there are dual circulation in the hand. So if radial is occluded, you can develop collateral through the ulnar. That's not an issue, but you cannot use radial once again. So I think that would be the first, the issue number one. I think a lot of new devices probably would need to be thought about, because of course the ideal scenario would be to try to miniaturize things more and more so that everything can be given transradially.